Welcome to McTox Curriculum, brought to you in collaboration with Western University, the University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum built for residents and fellows from PGY 1 to 5. This module has been created by Bandar Ba and will discuss antidiabetic drug overdoses. By the end of this session, learners will have an approach to the patient with an antidiabetic overdose, including how to differentiate between the different potential classes. We will also discuss the management of these patients and their potential antidotes. In our first case, you are called to see a 59-year-old man who is an admitted patient waiting in your department. He has a depressed level of consciousness and isn't responding to verbal or painful stimuli. The nurse found an empty bottle at his bedside. It's a prescription for 2 milligrams of glimepiride and is missing 20 tablets that the patient apparently took about 3 hours ago. His most recent vital signs are up on the monitor and show some abnormalities. The nurse looks to you for what to do next. What's going to be your approach in this scenario? This is clearly a sick patient, so we will go back to our ABCs. Ensure the patient is protecting his airway, and if not, move him into the left lateral decubitus position while you're looking for a quickly reversible cause for his altered LOC. Oxygen should be supplemented, he should be connected to a cardiac monitor, and an IV should be obtained as soon as possible. As you can probably guess, the first test that should be checked is the patient's count blood sugar. As a physician, you should be looking for other causes of this presentation while at the same time treating the most common etiology based on the information available, which in this case is a glimepiride-induced hypoglycemia. If the patient is not responding and we suspect hypoglycemia, an AMP of D50 should be given IV. In this case, our patient's initial cap sugar was 1.2. He responded quickly to a bolus of D50 and woke up to confess to the overdose on his glimepiride. He was started on an infusion of D10 normal saline at a rate of 100 mL per hour, but he did require 2 additional boluses of D50 over the following hours. In addition to resuming a normal oral diet, what antidote do you know of that may help reduce the need for multiple dextrose boluses? In the next few slides, we'll go over other available antidotes to treat an antidiabetic overdose. First up is glucagon. It's not an antidote that is commonly used in the hospital setting, but it is part of the EMS algorithm for managing hypoglycemia in the pre-hospital setting. Glucagon is administered by an IM route and is a great option for when there is no IV access. There is a delay in the onset of action, which is why it's not our first-line treatment in acute symptomatic hypoglycemia. Glucagon acts by releasing glucose stored as glycogen in the body in places like the liver. Patients with alcoholism, nutritional disorders, and the elderly don't benefit as much from glucagon in hypoglycemic episodes because their glycogen stores are not going to be sufficient. Another possible antidote is octreotide, which is a semi-synthetic analog of somatostatin. Octreotide inhibits the release of insulin from beta cells in the pancreas. It's helpful in antidiabetic overdoses because it reduces the risk of recurrent hypoglycemia, specifically after sulfonylurea and meglitidine overdoses. Administration can be subcutaneously or IV at a dose of 50 to 75 milligrams every 6 hours. Finally, there is an antidote you might not have heard of called diazoxide. This is a non-diuretic thiazide drug, and it has 2 main actions. First, it directly causes arterial vasodilation and can be used as a treatment of a hypertensive crisis. Secondly, it prevents insulin release from beta cells in the pancreas, similar to octreotide. For this reason, it can be used to treat a sulfonylurea overdose. Octreotide, however, was shown to be more effective and better tolerated due to diazoxide's intolerable side effects. Moving on to our other case. You have a 64-year-old diabetic lady who comes in with a history of overdosing on her metformin about 6 hours ago. Her regular medication list only includes metformin and aspirin. Her triage vitals look okay, and she is awake and responding appropriately. So what is the first blood test that you should order? And what would you expect our cap sugar to be at this point in time? You order the appropriate tox blood work, and a little while later her nurse calls you back to check on her because she started to look sick and she's getting concerned. Her blood glucose is 11.2, and her most recent vitals show tachycardia and a low BP. As you can see, her lactate and VBG are clearly abnormal. This patient has gone on to develop metformin-associated lactic acidosis, or MELA. It's hypothesized that biguanide inhibits oxidative phosphorylation, preventing aerobic metabolism and therefore increasing lactic acid production. It also prevents hepatic gluconeogenesis, which decreases the consumption of lactate. Risk factors associated with MELA are older age, renal impairment, liver disease, cardiovascular disease, and an acute overdose. Antidiabetics can be divided into two main groups, the hypoglycemics and the non-hypoglycemics. Medications that induce hypoglycemia do so mainly by increasing insulin release from the pancreas, like sulfonylureas and meglitinides, or by directly introducing exogenous insulin. Drugs that are unlikely to cause hypoglycemia include biguanides such as metformin, glitazones, and alpha-glucosidase inhibitors. Our questions for today's module are 1. Ingestion of what drugs will lead to hypoglycemia? 2. What electrolytes should be monitored when treating with IV dextrose? And 3. What are the similarities and differences between an ASA and a metformin overdose? And that's it. Thanks for watching, everyone.